All right, so good morning, everyone. Thank you so much for joining us this morning for today's Talk with a Doc, all about cataracts and eye health with Dr. Jules Winokur of Northwell Health. I'm Brooke Oliveri. I'm the manager of the Long Island Health Collaborative. For those of you who may not know, the collaborative is overseen by the Nassau-Suffolk Hospital Council, and we are a coalition of 300 plus hospitals, health departments, and community-based organizations from all sectors working to improve the health of Long Islanders. So firstly, I just want to thank AARP New York, our sponsor. We are super excited to be working with them for the second year on this Talk and Walk with a Doc series. And of course, I want to thank Dr. Jules Winokur of Northwell Health for taking some time out of his busy day to educate us about today's topic. So some housekeeping. Luckily, for those who registered and maybe couldn't make it today, the program is being recorded. I see someone asked that in the chat as well. So yes, you will be able to access this recording on our YouTube channel to watch at a later date. By participating, you are consenting to being part of the recording. We will have some poll questions before and after today's presentation, and we will also have an interactive Q&A session with Dr. Winokur. So please hold your questions till the end, and we will certainly get to them. Okay, so I have a lot of windows open here. Sorry for the delay. Okay, so before I hand it over to Dr. Winokur, we just have a few words about AARP. So on behalf of AARP, welcome to today's Talk with a Doc webinar. ARP is committed to helping you stay healthy and connected. So they congratulate you for taking the time to learn more with AARP and the Long Island Health Collaborative. AARP is a nonprofit, nonpartisan membership organization for people age 50 and older. There are 38 million members nationally, approximately 2.5 million in New York State, and about 500,000 living on Long Island. AARP works to strengthen age-friendly communities and make for happier, healthier residents of all ages. And they advocate for what matters most to people 50 and over and their families, with a focus on health security, financial stability, and personal fulfillment. You can learn more about other online classes, events, local discounts, volunteer opportunities, and more at aarp.org/nearyou. And once again, thank you so much to AARP for sponsoring this series. And now, one more final thing before I hand it over to Dr. Winokur. I know you are all patiently waiting to hear his insights. We do just have some pre-event poll questions for you to answer. So I am going to go ahead and launch those now. These survey questions, they help us to shape future programming, to assess your needs and where you are, so we can better, meet your needs through our programming. So if you wouldn't mind taking a moment to answer these questions, we would very much appreciate your feedback. So I'm just going to let these sit for a minute or two and allow everyone some time to answer. I see a lot of greetings from all across the nation in this chat. So welcome and thank you for joining us from near and far. It's the beauty of virtual programming, right? We all get to convene in one place virtually. So see a lot of responses coming in on the polls. Thank you so much for your feedback here. We are so appreciative of that. I'm just going to give it another maybe 30, 40 seconds, and then I will close this out. And you might be thinking, you're not really sure of some of the answers to these questions as far as, whether you're ready to adopt some of the tips that are shared in today's program, but we really just want to get a sense of, your feelings and sentiments before and after. So just please answer to the best of your ability, according to your perception. I see about 62% of our audience has participated in the poll. Thank you all so much. And I do realize, one of these questions is a little bit New York State specific. So just thank you for your feedback. Okay, I'm going to give it 5 more seconds. some other folks in the waiting room. I'm just going to let them in as well. Okay, it has been 2 full minutes. I think I'll go ahead and close the poll. Thank you all so much for your feedback. Oh, I haven't closed it yet. Someone did just say that it went away while they were answering. I'm so sorry. Okay, I think it's been 2 minutes and 30 seconds. Thank you all so much for your feedback. I am going to go ahead and close the poll. Okay, so now I would like to introduce our speaker today, Dr. Jules Winokur. He is Vice Chair of Ophthalmology at Long Island Jewish Medical Center and North Shore University Hospital. And without further ado, I would like to hand it over to Dr. Winokur. I will stop sharing my screen. Oh, Dr. Winokur, you are on mute.
Fantastic. All right. I knew I was going to mess something up. So thanks very much for having me, Brooke, and looking forward to talk to all of you today. I'm going to share a little presentation here. Let's go ahead and get right into it. There we go. Okay. So let's start with some basic stuff, right? The eye is a sensory organ. It helps us to see the world, and it helps us just navigate our lives. And when people come to the eye doctor, they're typically coming for either vision loss, vision problems, some sort of visual issue, or pain. And just to get a bird's eye view of what the eye does, this is a schematic of the eye, and basically you can see over here, the front of the eye is called the cornea. It's a clear dome of tissue. And then right behind that, behind the iris, sits a lens. And together, the cornea and the lens, they focus everything to the back of the eye so we can get that image into our brain and see it. So if you think of the eye like a camera, you've got a lens of a camera and you've got film in the camera. And the lens of the eye is part of that focusing system that we use. And that's what helps us see and what helps us focus. Now, normally when you take a look at an eye, the light's going to come right into the eye. It's going to come through the cornea and through the lens and through that pupil, and we'll focus it on the retina, and then our nerves bring that picture into our brain. And just as a graphic representation of an eye, this is light coming in. This blue circle over here is your lens, and that's what helps us to focus and what helps us to see. Now, cataracts affects the lens of the eye, and it is the most common cause of a painless, progressive, reversible vision loss. So we can cure cataracts and we can fix people. More than half of people over the age of 80 have cataracts or have had cataracts that have been operated on. And the symptoms typically include blurry vision, some night vision problems, sensitivity to light, glare or halos, driving issues, needing for more light, difficulty reading, or glasses that just keep changing. You get a new pair and then a few months later it's different and you keep going back. You keep getting new glasses. It can change our color perception. Everything looks a little bit more yellow when we get a cataract. And sometimes it even causes double vision in one eye. Now, this is what a lens looks like. And the top picture over here is a clear lens, and that's what we're born with. That's what we've got. But as we grow, that lens grows. And as that lens grows, it starts to lose flexibility. And that's why we need reading glasses in our 40s. And then it starts to lose clarity as we get older. And so then it really does become a problem for our vision and for us to see. And these are just a few clinical pictures of what a cataract might look like in our office. So you can see this top picture over here, even though you can see through the lens, you can see that there's this debris in the lens, this, for lack of a better word, schmutz on the lens that you can't see through. And this is a picture over here with a cross section of a lens that shows those same opacities, and it really does block the vision. And here's a picture of somebody from my office who just has this right through the middle of the vision, this little opacity through the lens. And this would be a more severe cataract. This would be, you can compare one eye to the other, and one eye has a nice normal pupil, and the other pupil is white. And so cataracts come in different flavors, different shapes, different sizes, different opacities, but the end result's really the same, and that's some sort of loss of vision. And so when the light comes into the eye through a cataract, that lens gets dark, and then the light getting through just doesn't penetrate well, and we don't see well. The way we treat cataracts is with surgery. It's a surgical fix. There are no drops to fix cataracts. You can't really use glasses to get rid of cataracts. It really is surgical. And the question is always, well, when am I ready to do surgery? When is my cataract, quote, ripe? A lot of doctors will use that word. And honestly, there really is no such time. It really is when you have vision loss from a cataract, and that's affecting your life in some way. It's affecting the way you live. It's affecting the way you drive. It's affecting your enjoyment. So we have people come into the office all the time with small cataracts who don't notice them. And we don't run to do surgery on these people because they don't really have much to gain. But as that cataract gets worse and your daily activities become more hampered, then we start saying, all right, maybe we should start doing cataract surgery. And usually we'll have a conversation with the patient in the office. Cataract surgery is the most common surgery in the United States, performed over 3 million a year. 3 million people with cataracts are having surgery every year. Just to give you some history on this, cataract surgery has been around a really long time. We see evidence of it in Sanskrit manuscripts, and the Code of Hammurabi said, if a doctor shall cure someone of a cataract, they shall get 10 shekels. And this is from the Middle Ages where they would hold people down in a chair. Thankfully, we don't do that anymore. Today, the surgery is so elegant and the results are so good. We have lenses that go into your eye. They're smaller than a dime and they restore your vision. And it's really a painless procedure that usually takes less than a half an hour for most people to have. The way we do the cataract is we actually have microscopic incisions through the edge of the cornea that we introduce instruments into the eye. And we segment the lens into smaller pieces that we can then break up and vacuum out of the eye. And when we're done with that, we'll usually inject a lens so that we can see again. So this is all done through microscopic incisions that most of the time close on their own without any stitches. So it's really kind of an amazing, elegant procedure. There are different ways that we do it. And a lot of times when people come into the office and they're ready for cataract, there are a lot of options that we have to talk about because there are a lot of choices. And so I'm going to take you through some of that. There's the conventional surgery, and that's covered by insurance. That's what we do a lot of the time. We do it by hand. We're making the small incisions. We're breaking the lens up into smaller pieces. We're opening the membrane that the cataract lives in, and we're using an ultrasonic probe that vibrates, that breaks the lens up into smaller pieces. There's something relatively newer out there called femtosecond laser cataract surgery. So you'll hear a lot of people saying, oh, I had laser surgery. And what laser surgery does is it actually uses a computer and a sophisticated imaging system to actually scan the eye. And it uses a laser to open that membrane. So it's no longer done by hand, it's done by a computer. In about 1 second, it opens up what takes us a little bit longer to do. It actually uses a laser to divide the lens up into smaller pieces and then actually subdivides those pieces. So it's even smaller and softer. The machine also fixes a little bit of astigmatism of the eye. I'll get into that in terms of what that is. You still have to remove the lens with the ultrasonic probe, but it's a lot less energy that's required. And unfortunately, that is not covered by insurance. But the long-term results are actually equal in the two eyes. So if you look at somebody who's had a laser surgery, and you look at someone who's had a conventional surgery a few years down the road, we're not seeing much of a difference. The advantage is really for people who want to have less energy in the eye and want to fix a little bit of astigmatism at the same time. This is one of my colleagues performing the surgery with the laser surgery. And you'll see what we do is we put a little device on the eye that holds the eye in place. And then we put them under a machine here. And what that does is there's a computer that then looks at the eye. It's taking a picture of the eye. It's scanning the eye. So here we can see the cornea. We can see the lens. We can see all of these things. And once we agree with the computer, it shows us a picture of what we're doing. It then goes ahead and it does the laser. And you can see the laser being done right now. And the laser is going to take about 20 seconds to do. It's opening up the membrane. It just did. And now it's basically putting the lens into pieces. And you can see a little cross section on the lens of the pieces and the softening and some corneal incisions that help reduce the astigmatism. So in about 20 or 30 seconds, you've done about half the surgery right there. And then we go to the operating room and we do the rest. So that's sort of how we do the surgery. The other question that we get a lot is, what kind of lenses can I get and what kind of results can I expect? And I find the history of this kind of fascinating. When we did cataract surgery prior to World War II, you just removed the lens and that was it. And you really had to wear very, very thick Coke bottle glasses. So this is a picture of my Uncle Ben, who had a surgery done around World War II. Basically, he wore thick magnifying glass. And you may remember your parents or grandparents walking around with these very, very thick Coke bottle glasses as they get older. And that's because the lens was removed and there was no replacement. So you had to wear these glasses. And there were issues with the glasses that were heavy. The quality of vision wasn't amazing. And nobody really thought to put a lens in the eye until after World War II. During World War II, there were a lot of pilots that were shot down, and the cockpit glass would actually get into the eye. And prior to this, we didn't put anything in an eye. Anything you put into the eye would cause trouble. But there was one doctor in the Royal Air Force, Sir Harold Ridley, who took care of a lot of these pilots that had the glass in the eye and they couldn't have surgery to remove it right away. So they were transferred to different states. And when he would see them, the glass didn't react with anything. And he's like, wow, if this glass doesn't react in the eye and the eye's doing okay, maybe I can make a lens out of it. And so the first implant was done in 1949, where they actually made a lens out of the material of the glass, which was something called PMMA, and very controversial at the time, but it changed the world in which we live. And now we can actually put lenses in the eye. And the lenses we put in are foldable. They're made of plastic. They're injected into the eye, into the membrane that the cataract originally lived, and they help us to see. And that's a schematic. And here's a real life patient of mine who's had surgery and has a lens in the eye. You can see it's right behind that membrane of the eye, and it helps us to focus, and it really does restore vision. Now, there are a lot of different lenses out there, and this can be very confusing when you're going to the eye doctor for the first time and you're talking about cataract surgery, and it's hard enough to wrap your head around having surgery, but then you're presented with a whole list of choices of, well, what kind of lens do you want? So I'm going to try and break that down a little bit for us. So we'll go with the standard lens. Let's start with that. Standard lenses are covered by insurance. They are high quality implants. They're really, really excellent, but there are some limitations to the lens. So number one, there's only one distance that can be focused by the lens. The lens doesn't change strength. So we sort of have to pick, what do you want to see? Do you want to see distance without glasses, or would you rather read without glasses? How do you want to live your life? And we have to figure that out. So we can do one of those, but not both with the standard lens. Really excellent quality of vision, excellent contrast sensitivity, covered by insurance. It's not a bifocal. So you're not going to read without glasses and see distance without glasses. You're going to need glasses for one of those. And it doesn't correct astigmatism. So if you have astigmatism, you end up needing glasses both for distance and for near. There are special lenses that correct astigmatism. These are called toric lenses. So they're very similar to the standard lens, but they do help people who have astigmatism live without glasses, at least at one distance. So if they said, well, I have astigmatism, but I'd really like to not wear glasses at the distance, it's a really fantastic lens. Unfortunately, it's not covered by insurance because insurance companies think, well, you can just wear glasses, so we're not going to deal with that. So what is astigmatism? I'm sure a lot of you are asking. So basically what astigmatism is, it's instead of the eye being perfectly round, it's actually distorted. So the surface of the eye, the cornea, is a little bit more like a cylinder. And so when light gets focused in the eye, it's actually getting focused in different ways, and you're getting images, multiple images at once, and when you put them together, they're a little bit blurry. And so everything is a little bit not clear. So this is an eye that has astigmatism, and you can see that we're sort of having, instead of one focus on the back of the eye, there's two focuses. And so you actually need two different strengths of the lens, sort of, to focus everything together, and that's what these astigmatism lenses do for you. It can also be corrected with the laser. We can sometimes change the shape of the cornea with these incisions, but depending on how much astigmatism you have, there may be one better than the other. And this is what an astigmatism lens looks like. And basically, it looks like a regular lens implant, but you can see there are little marks on the lens. These lenses have to be implanted just right in just the right direction in order to correct the astigmatism. So it's a little bit more subject to movement and things like that. Now, there are people who say, I don't want to wear any glasses. They come to my office and we talk about cataract surgery, and they say, I don't want to wear glasses at all. And that's a little more difficult to achieve, but it's not impossible. There's something called a multifocal lens. A multifocal lens focuses everything at once. It's going to focus as if you were looking far away, and it's going to focus as if you were looking at a computer, and it's going to focus as if you're reading a book. So you're getting multiple images that are focused at once, and your brain has to figure out which image it's going to pay attention to. you can achieve excellent distance vision and excellent reading vision, but these lenses do come with some glare and halos. So at night, when you see a light, you might see rings around the light, and that's just how the lens works. You have a little bit worse night vision with this. It's about 94% of what you're getting with a regular lens. And your shades of gray are a little bit harder to distinguish with these lenses. It's not covered by insurance. For me, this is really for people who don't want to wear glasses, and that's their primary goal. They don't mind living with a little bit of compromise of those glare and halos, or of that, little bit of contrast sensitivity. So again, it really depends on the person. People looking say, I want perfect distance vision. I want, they're very meticulous. This may not be a great lens for them. It also doesn't work well if you have retinal problems or other conditions in the eye. So, I'm always a little bit more careful in terms of who's going to get this lens and who it's appropriate for. The last lens I'll talk about today, and then I guess we can open up to questions, is something called the light adjustable lens. So when we do cataract surgery, we have to figure out what kind of lens to put in your eye. And that lens is based on the shape of the cornea, which is the front of the eye, which does some focusing, and also how far away is the retina from the cornea. So the length of the eye, where's the target that we need to focus? Now we're going to use a lot of different formulas to figure this out. And can always be a little bit of an error in the math. And that can be due to either a measurement that's not good, or an error in the formula, meaning the formula is not right for your eye. There are different formulas, and we compare lots of different formulas when we're picking a lens, but there's no one formula that's perfect for every person. And so little errors of these formulas sometimes leads to glasses. In general, we're accurate about 75 to 80% of the time with any given formula to get you within half a step of where you want to be. Again, if you're looking for perfection, sometimes you're like, gosh, I wish I got a little bit stronger or a little bit weaker, or I wish I had the chance to test drive it. And that's sort of where the light adjustable lens comes in. A light adjustable lens is a lens that can actually be changed in the office using a special ultraviolet light. So basically we would do the surgery, and then within a few weeks of the surgery, you'd come into the office and we would check you for glasses. And any prescription that's there, we would go ahead and we would just put it into that lens without another surgery, without another thing. So it's for people who really don't want to wear glasses at the distance or glass at the near, and they really want it customized as much as possible. I think it's a great lens with good quality. The downsides are it requires multiple visits to the office because we basically have to go in, check you, make sure the glasses are, the prescription is where it is, put that into the lens, make sure we got the right result. We can do it again and then do it again if we have to, and then we eventually lock it in. And until we've locked it in, you have to wear a special pair of ultraviolet glasses over your eye to prevent the lens from accidentally being triggered. So you don't want to accidentally, spend all day in the sun and then accidentally change your prescription. The lens is not covered by insurance, and that's a downside. And here's a little video of a lens that's being treated, and we just put our logo on the lens. So this is a lens that's there, and we can use laser light to make any shape change we want. So whatever we want to do, we can actually do with these lenses within certain parameters. And I think it's a really, really cool technology for people who are looking for perfection. So I'll sum it up. The eye in general is a sensory organ. It helps us to see the world around us, and cataracts are universal. Doesn't mean there's anything wrong with you. It's not a bad disease. We are all getting cataracts, and at some point in our life, we're going to want to deal with it. We can treat it with surgery, and we can restore normal vision. We can restore even oftentimes better vision than you had, when you were wearing glasses. Newer technologies can reduce some of the risks that are associated with ultrasound energy, and the lens implants can really give all of us a really fully customizable visual outcome depending on what we want. So thank you so much for your time, and I'm happy to take any questions.
Thank you so much, Dr. Winokur. So anyone, if you'd like to unmute yourselves, you can ask a question that way. You can raise your hand, or you can put your question in the chat if you would prefer. I do see one question in the chat. What are good questions to ask my eye doc before deciding on surgery?
Well, I would say what's bothering you? What do you want to fix? Where do you want to be? How much is this impacting your life? And then I would talk to the doctor about what options you have for surgery, what's being offered, what's out there. You know, a lot of stuff that we do here changes, and technology is constantly evolving. You know, so I would just have that conversation with your doctor, and I'm sure your doctor who does the surgery has had this conversation thousands of times. So I'm sure they have their speech that they can give you, and they can talk to you all about the risks and all of those things.
Excellent. Someone else asks in the chat, how about nutrition? I guess, does nutrition have an effect on cataracts at all?
Yeah, so you know, there aren't really any supplements I could tell you to take, like vitamins that'll prevent cataracts or things that will take it away. I think in general, having a well-balanced diet and a healthy diet is a good idea. You know, cataract is not just brought upon by age, it's brought upon also by trauma, and certain diseases can do it, diabetes can do it. So for people who are diabetic, I would always say the more controlled your sugar is, the better off you'll be. People who have wild swings in blood sugar often have developed what are called diabetic cataracts or sugar cataracts. So, you know, but I think for the average person, as long as you keep a normal diet, there's not much more to do.
Great to know. Are there new technologies coming for the treatment of cataracts?
There are always things in the pipeline. You know, ideally, we'd love to have a lens that can accommodate, meaning a lens that can focus on the distance, and then using a muscle in your eye, you could read up close and not have to wear a pair of reading glasses. But everything that's been tried up to date, and there have been attempts, has really not been phenomenally successful. So maybe one day, but not right now.
Okay. Two questions similarly ask, you know, whether a person is asleep during the surgery, what kind of anesthesia does this require?
So the anesthesia depends a lot on who's doing the surgery, patient preference, and things like that. The majority of my cataracts are usually under what's called topical anesthesia. So you're awake, you have an IV, we do it in an operating room or a facility, a surgery center facility, with an anesthesiologist there. Usually people get a little bit of something to help them relax, because there is some anxiety that people have when they have surgery, but they are awake. The anesthetics that I usually give are topical, meaning I put drops on the eye, and then we supplement with a little bit of anesthesia in the eye itself. The surgery is fairly quickly in general for most people. And the advantage of that anesthesia is that you are basically able to leave without any issues. Your recovery is faster. You can use the eye that day. So people often say they can see already the day of the surgery.
Wow.
Other alternatives, sometimes we will actually give an injection around the eye to numb that eye up. We call that a block. And in certain cases, in people who can't stay awake, we do put them under general anesthesia. But the risks of general anesthesia are usually so much higher than the risks of surgery. And so, you know, it's really a risk-benefit analysis that your doctor makes along with the anesthesiologist, and you have input in that as well.
So you kind of just touched and segued beautifully into this next question I see here. What are the risks associated with surgery?
So usually that's a long conversation. I'm happy to go over that with you guys. In general, 95% of people that have cataract surgery have no problems. I would say about 5% have minor complications that end up with the same results as everyone else. So maybe the surgery took a little longer, maybe the recovery took a little longer, but the end result is really going to be the same. Very, very rarely there are bad things that happen. There's a 1 in 1,000 chance of bleeding in the eye, 1 in 10,000 chance of infection in the eye. There's a chance that you'll need more than one surgery to cataract out. You can have glare and halos with any lens implant that's out there, whether they're a premium lens implant or a standard lens implant. These lenses are basically plastic that sit in the eye, and sometimes that can cause some glare and halo. You may need surgery for other problems that happen to the eye after surgery. You can develop retinal problems, corneal swelling, glaucoma. It is surgery. You name it, anything can happen. In a worst case scenario, you can lose vision, go blind, or lose the eye. The odds of that happening is incredibly small. It's like saying every time you leave the house, well, it's cloudy today, I might be hit by lightning. Statistically, that's not false, but that's not really a realistic way to approach life and to live your life. So for us as doctors, we always say, you know, well, risk benefit. What's the risk? What's the benefit? If you have no benefit, meaning your vision's good and you have no complaints, then the cataract's not right, and we're not doing surgery. If you say, I can't drive at night anymore, I'm worried I'm going to get into an accident, that's a huge benefit. And there are many studies that looked at the clarity of vision, and overall health outcomes. And it's been shown in the medical literature that people who have cataract surgery, they do better in life, less falls, less issues, just getting around, better mental status, things like that. And so I think that, again, it's a very personal thing. There's no set number that or a set date that says you have to have a cataract by a certain date, but you know it. You come in, you say, I'm struggling. And it's an elective surgery. So as patients get the last say, they can choose to do it and they can choose not to do it.
Very insightful. So in the realm of prevention, I know you kind of mentioned that cataracts are somewhat inevitable. We are all kind of moving that way. Is that correct? And the second part of that question is there anything, lifestyle changes that we can make to prevent the onset of cataracts?
I wish there were, but it happens when it happens. And that's, partially genetic. I've had people very young get it. I've had people, in their late 30s that come in with an age-related cataract that need surgery. And I've had people, I think the oldest patient I've ever operated on was like 104 for a cataract surgery. So when it happens, and you deal with it when it becomes an issue for you.
That makes sense. A lot of questions ask, does cataract surgery need to be repeated, or is it one and done? Is it permanent, or could it reverse?
So it is one and done, meaning once the lens is out of the eye, it's not grow back, it doesn't come back. What some people do experience, I think about 30% of people who have had cataract surgery can develop a little scar tissue behind the lens implant in the membrane that originally held the cataract. And that can happen months to years after cataract surgery. And that can be fixed in the office. We use a laser in the office to actually break away the scar tissue and give you light again. So the cataract doesn't come back, but sometimes people get what's called this posterior capsular opacity. Some people call it a secondary cataract, but it's actually fixed in a much easier way in the office with a laser. That takes about 5 minutes, and usually the vision comes back that night to what it was after the surgery.
Okay. There are a few questions in the chat relating to, I'm not sure if I'm saying this correctly, myopia, and whether there are specific questions that patients with that condition should ask prior to surgery.
So glasses come in like 3 flavors. We spoke a little bit about astigmatism, that's one flavor, and then there's myopia and what's called hyperopia, or the colloquial term is nearsighted or farsighted. People who are myopic are nearsighted, so they can lift their glasses up and they can see up close, and farsighted people are better distance vision than near vision. It doesn't really matter, meaning the lenses really come in a wide range of corrections. So people who are myopic and have been myopic their whole lives really don't have to be myopic anymore after cataract surgery. It really depends on what they want. I have many people who actually are myopic. They're used to going like this when they read, and that's what they want. They say, I love reading without my glasses. I read in bed, and that's where I get my most enjoyment. I don't want to wear glasses for reading. And so we'll, I'll work with them, and we'll work to retain that, and they'll still wear glasses for distance. So almost any visual issue that's glasses related can be corrected at the time of cataract surgery.
That is super interesting. There are so many questions in this chat. I have to say, I don't think we're going to have time for all of them, unfortunately. How does 2 or 3 more sound to you, Dr. Winokur?
I'm here for you, whatever you want to do.
Okay. Oh boy. Okay. So are all people good candidates for the adjustable lens? How many sessions does the adjustment take? That might be a little specific.
So not everyone is a good candidate. Your pupil has to dilate a certain amount. You have to be within the range of powers that the lens comes in, which is an extensive range, but still you have to be within that range. And it's, like I said, it's a lot of visits. Usually about 17 days after surgery, we start. We usually do about 3 treatments. Meaning to change the prescription, you get 3 chances to fix it to whatever it's going to be, and then you usually lock in with 2 more treatments. So in addition to our typical post-op visits, which is usually a day, a week, and a month after surgery, we do those visits. So it's actually a lot of time by both the doctor and the patient to get it right. And usually the visits are long because you want to make sure that when we're doing this for what you want. Some people say, I want you to make one eye distance, then I want to use a computer with the other eye, and we sort of play around with the lens to figure out what that prescription would be But yeah, it is not everyone is kin.
Okay. In the same vein as some of what you just discussed, what happens when you only need cataract surgery on one eye, and how does the other eye that doesn't need the cataract adjust? Would that be a problem, especially with those lenses you discussed?
So usually if they only need one eye, we only do one eye. The only exception to that is, let's say somebody's very nearsighted, right? And they have very, very thick glasses and they don't want to wear the glasses anymore. And so we'll do one eye and we'll set it for the distance. And that works great. But now they've got one eye with no prescription and one eye with a very high prescription. And that's very uncomfortable to deal with in glasses. And the options are, you can wear a contact lens in the nearsighted eye, and that fixes the issue, but it's annoying. Or you can do cataract surgery maybe a little bit earlier than you normally would, so you can get that balance back restored. But usually most people are symmetric. Usually if you have it in one, you have it in the other.
Mm,
But it has happened with one.
okay. First for everything, I'm sure. And trying to pick our one closing question here. Would anybody like to unmute themselves and ask their question live? Just an idea. If not, that's okay.
I have some questions.
Okay, we have time for one more. So
Okay.
Please ask away.
I'm gonna ask two, if you can only answer one.
I'm only answering one. No, I'm
Okay.
kidding. No, you can ask it.
What's the recovery process?
So in general, for routine surgery, I would say people are leaving the operating room. They are seeing. They see us the next day in the office. Usually they go home. We put a plastic shield on the eye just to protect us. They don't rub the eye. Typically, they start their post-op drops 4 times a day. And they're on those drops for about a month. And we change the dosage based on the visit and based on how you're doing. But usually we taper that off. And then we'll see a week later and then a month later. And at the end of the month, if you need glasses, we'll give you glasses. But like I said, we do our best to help people achieve independence from glasses. But sometimes you do need a little prescription. Sometimes it helps, maybe just when driving in the car, but they don't need it during the rest of the day or whatever it is. So usually I tell people it'll take about a month till we're sure about the prescription.
Thank you so much, Dr. Winokur.
Is there a second? I feel bad. I don't want to cut you off. Was there a second question?
I was just wondering, how long should you wait? If you need both eyes done, you have one eye done, then have the second one.
Usually most places require you get a medical clearance before you have surgery. That means you have to see your doctor, if you have heart problems, your cardiologist before having surgery. Usually that permission for surgery or clearance for surgery is good for about a month. So we'll try and squeeze both eyes in that time window. But honestly, as long as they're not, a lot of us don't do them on the same day. We don't do both eyes on the same day for various reasons. We don't want to expose both eyes to the same risks on the same day. We do one eye, make sure you're okay before you do the other eye. But honestly, you can separate it, by as little or as much as you want. I've had people ask me to do it a few days later, and I've had people wait till they're ready. So really up to you.
Thank you.
All right.
Thank you all so much for your participation. We do just have one final slide of information for you. You may or may not know the rate of pedestrian injury and fatality in New York State is quite high. So we usually typically encourage walking as, a healthy lifestyle choice to prevent chronic disease in these programs. Unfortunately, I don't think that works very well for cataracts, but if you are walking in New York State, always use the sidewalk. If there's no sidewalk, walk facing traffic. And you can find other tips for walking safely at walksafeli.org. And we do just have some closing poll questions for everyone, if you would be kind enough to answer them. So I just want to once again thank AARP, thank Dr. Winokur, and thank everyone in attendance here for their time. We are so appreciative of your participation. And if you would take a moment to just answer these poll questions, your feedback is very important to us. So I thank you in advance for providing that feedback. And I did put the link in the chat to where this recorded program will be available. I'm just going to put it in there one more time for anybody who would like to see it at the top there. No matter what the topic is, I always learn something new, especially as someone with an astigmatism. So thank you so much for all of this knowledge. And it sounds like I'll eventually need it no matter what. Cataracts seems somewhat inevitable, so thank you.
Thank you so much for inviting me, and thank you everyone for coming. It was really nice to see so many participants, so appreciate it. And I hope you guys got something out of it, and you do well. All right.
A lot of great feedback in the chat, so thank you once again. You did a great job. I am just going to leave the polls open for just another minute or two here. If you've already answered, thank you so much for your feedback. Dr. Winokur, of course, feel free to, leave and go about your day. We know you're very busy. So just want to say thank you once again.
Thank you.
And I'll just leave these polls up for another 10, 15 seconds. Oh, it looks like everyone in the meeting actually participated. So thank you all so much. And hopefully we will see you again next year for our 3rd annual series. Have a great day, everyone.